After studying this module, you shall be able to learn about the meanings in different types of dementia, learn the criteria of clinical diagnosis of Alzheimer's disease, learn about the major brain areas and their pathology as well as neurotransmitters involved in Alzheimer's disease, learn about the neuropsychological symptoms of Alzheimer's disease, learn about the treatment and prognosis of the disease. Dementia is a syndrome which is progressive in nature, that is, progressive cerebral failure. It is a degenerative disorder involving the compromise of multiple domains of cognition. The further classification of dementia based on clinical presentation or on etiology is, however, fraught with difficulties. Despite this emerging view since mid-1970s, there has been that dementia can be classified into, based on the site of damage, various categories. Types of dementia. Dementia may be classified into two categories, cortical dementia and subcortical dementia. In cortical dementia, grey matter deteriorates cortical abilities, can be categorized as subserving instrumental functions such as language, perception, memory and calculation. Memory impairment is characterized by greater deficit of encoding and storage of new material. In cortical dementia, senile plaques and neurofibrillary tangles populate the cortex and there is generalized cortical atrophy, especially of the frontal and temporal lobes. The neuronal degeneration affecting particularly outer three layers. In terms of cognition, evidence suggests that cortical dementia evolves and develops differently from subcortical dementia. Stern in 1998 evaluated cognitive changes over 1 to 3 years prior to the time dementia was diagnosed in 40 matched pairs of patients with cortical and subcortical patients. The results showed decline in naming on the Boston naming test and in performance on the selective reminding test. The decline was more rapid in subcortical than in cortical dementia. There is evidence to suggest that patients with cortical dementia are disproportionately impaired in category fluency as compared with letter fluency, a fact that comfortably fits with more severe semantic memory problems. It has also been claimed that cortical dementia is characterized by accelerated forgetting. In this kind of dementia, extensive remote memory loss with some degree of relative sparing of early memories is found. This is specific for autobiographical memories as opposed to memories of famous events. In subcortical dementia, white matter is disrupted. Subcortical structures include the basal ganglia, diencephalon, thalamus and hypothalamus, and mesencephalon, midbrain and cerebellum. They have a role in arousal, attention, mood, motivation, memory, abstraction, and visuospatial skills. There is a marked psychological incompetence associated with minimal memory loss. There is absence of aphasia, apraxia or agnosia. Characteristic symptoms of subcortical dementia are forgetfulness, showing of thought processes, mild intellectual impairment, apathy, inertia, depression, and inability to apply knowledge. Difficulties in problem solving and abnormalities of judgment and insight may occur. Subcortical dysfunction slows information processing and adversely affects memory, cognition, mood and motivation. Memory impairment is characterized by greater deficit of spontaneous recall. As a result, memory assessed by clues and recognition test is usually superior to free recall. Articulation and verbal fluency is impairment, but language is spared. The lesions occur predominantly in the basal ganglia, the brain stem nuclei and the cerebellum. In addition to clinical features of underlying disease, Parkinson's, Huntington's and others, psychiatric disturbance, bradyphrenia, frontal executive dysfunction and impairment in memory, which is characteristic of subcortical dementia, may be present. Psychiatric manifestations of subcortical disease come primarily in the form of personality changes and affective disorders. Apathy and irritability are common, found by Arsenault et al. In 1999, and depression is said to be significantly more common in subcortical than in cortical dementia. Arsenault et al. In 1999 found that 38% with Huntington's had depression. Slow thinking has been demonstrated in both Parkinson's and Huntington's and is independent of motor slowness. Frontal executive functions evidenced by difficulties with verbal fluency, set shifting, categorization and planning are also disturbed. Learning impairment is also present, which can partially be corrected by providing richer cues to encourage learning and promote recognition. In Huntington's, there is a flat, uniform loss of remote memories across all earlier periods. There is a difficulty in dating past events. Alzheimer's disease. Alzheimer's disease was named after its discoverer Alois Alzheimer. According to Perry and Hodges in 1999, Alzheimer's disease for a very long time considered as dementia. It was characterized by global cognitive impairment, and indeed little distinction was made between types of dementia. Earlier studies often referred to senile dementia and probably included patients with various etiologies, including multi-infarct dementia, cortical levi body disease and frontotemporal dementia, as well as Alzheimer's disease, found by Perry and Hodges in 1999. Later on, with the detailed examinations and further researches, Alzheimer's was characterized as a distinctly different disorder. Alzheimer's disease has been defined by McCann et al. In 1984 as a brain disorder characterized by progressive cortical dementia. Alzheimer's disease is irreversible and thus results in an inevitable decline. Most devastating and prevalent of dementia, Alzheimer's represents one of the leading causes of death overall for people older than 65. No single cause can be ascertained for AD, and the causative factor in majority of cases remains unknown. AD is invariably linked to increased age that leads to speculations that it is a disease of accelerated aging, which directs us to the apparent fact that if everyone lived long enough, Alzheimer's would be inevitable. According to Sheshadari et al. In 1997, over a lifetime, women are about twice as likely to experience development of dementia or AD as men. This may be partly be accounted for the fact that women have a longer life expectancy, found by Mayo 2003. People who are more educated appear less likely to develop AD, probably because larger cognitive reserves act as a buffer against this neuropathology. McCann et al. In 1984, in their paper on clinical diagnosis of Alzheimer's disease, report of the NINCDS ADRDA work group under the auspices of Department of Health and Human Services Task Force on Alzheimer's disease reported the criteria for clinical diagnosis of Alzheimer's disease. National Institute of Neurological and Communicative Disorders and Stroke and the Alzheimer's Disease and Related Disorders Association established work groups on the diagnosis of Alzheimer's disease and came up with the criteria which has been provided below in the table. McCann et al. In 1984 also provided a cautionary note stating that because knowledge about the disease is still insufficient and incomplete, these criteria cannot be considered to be fully operational. Though these criteria are compatible with definitions in the current Diagnostic and Statistical Manual of Mental Disorders 3, as DSM-3 was used when these criteria were established, and in the International Classification of Disease, these criteria must be regarded as tentative and subject to change. Criteria for clinical diagnosis of Alzheimer's disease given by McCann et al. In 1984. The criteria for clinical diagnosis of probable Alzheimer's disease include dementia established by clinical examinations and documented by the mini mental test, blessed dementia scale, or some similar examination and confirmed by neuropsychological tests, deficits in 2 or more areas of cognition, progressive worsening of memory and other cognitive functions, no disturbance of consciousness, onset between the ages of 40 and 90, most often after the age of 65, and absence of systematic disorders or other brain diseases that in and of themselves could account for the progressive deficits in memory and cognition. 2. The diagnosis of probable Alzheimer's disease is supported by progressive deterioration of specific cognitive functions such as language, aphasia, motor skills, apraxia, and perception, agnosia, impaired activities of daily living, and altered patterns of behavior. Family history of similar disorders, particularly if confirmed neuropathologically, and laboratory results of normal lumbar puncture as evaluated by standard techniques, normal patterns of non-specific changes in EEG such as increased slow wave activity, and evidence of cerebral atrophy on CT with progression documented by serial observation. 3. Other clinical features consistent with the diagnosis of probable Alzheimer's disease after exclusion of causes of dementia other than Alzheimer's disease include plateaus in the course of progression of illness, associated symptoms of depression, insomnia, incontinence, delusions, illusions, hallucinations, catastrophic verbal, emotional or physical outbursts, sexual disorders, and weight loss. Other neurological abnormalities in some patients, especially with more advanced disease and including motor signs such as increased muscle tone, myoclonus or gait disorder, seizures in advanced disease, and CT normal for age. Features that make the diagnosis of probable Alzheimer's disease uncertain or unlikely include sudden apoplectic onset, focal neurological findings such as hemiparesis, sensory loss, visual field deficit, and incoordination early in the course of the illness, and seizures of gait disturbances at the onset or very early in the course of the illness. 5. Clinical diagnosis of possible Alzheimer's disease may be made on the basis of dementia syndrome in the absence of other neurological, psychiatric or systemic disorders sufficient to cause dementia and in the presence of variations in the onset, in the presentation or in the clinical course, may be made in the presence of second systemic or brain disorder sufficient to produce dementia, which is not considered to be the cause of dementia and should be used in research studies when a single gradually progressive severe cognitive deficit is identified in the absence of other identifiable causes. 6. Criteria for diagnosis of definite Alzheimer's disease are the clinical criteria for probable Alzheimer's disease and histopathologic evidence obtained from a biopsy or an autopsy. Major brain areas affected by Alzheimer's disease. Pathophysiology of AD are marked by two interesting facts. First, that specific regions are targeted by the disease, and second, huge neuronal loss and atrophy is suffered by the targeted structures. The AD, being a cortical dementia, affects major areas of the cerebral cortex. It significantly affects major subcortical limbic system structures also, such as the hippocampus and amygdala. Pathologic changes can be seen in the cortical tempoparietal association areas and the subcortical limbic cortexes to a large extent, as the disease specifically is responsible for destroying the major pathways to and from the hippocampus, cutting off direct connections to association cortices. Cortical atrophy has been ascertained by the gross post-mortem inspection of the brain. Along with the atrophy in the frontal, temporal and parietal cortices, thinning of the gyri and widening of the sulci can also be noticed. Massive cell loss can be observed in parietal and temporal cortices, the hippocampus and the structures leading to it, entorhinal cortex and the performant neural path, the amygdale, the specific nuclei of the thalamus, sparing the primary motor and sensory areas, tactile, auditory, visual, and the basal ganglia. Implications of the deficit can be seen in certain areas of the frontal lobe, such as the nucleus basalis, minor and the olfactory areas. This tells us that in Alzheimer's, more basic sensory and motor abilities are left untouched, while structures corresponding to the areas of higher cognitive functioning and memory are severely affected. Histologic markers. Alzheimer's in 1907 and 1987 identified two neuropathological findings regarding Alzheimer's disease: neurofibrillary tangles and neuritic or senile plaques, which are considered the primary markers of the disease. According to Zillmer et al. In 2008, neurofibrillary tangles resemble entwined and twisted pairs of ropes within the cytoplasm of swollen cell bodies. Tangles consist of proteins termed tau proteins, which are believed to accumulate as a result of abnormal phosphorylation. The excessive collection creates tangles that are dispersed throughout the brain, but disproportionately in the areas just listed, including the tempoparietal areas and the hippocampal complex, found by Zillmer, Spears and Culbertson in 2008. Alzheimer's described neurotic plaques as clump-like deposits in the neuropil. They are round aggregates of cellular trash that have a particularly affinity for the regions where the majority of synapses lie, that is the neuropil. The synapses eventually disintegrate, leaving holes and neuritis, that is pieces of axon and dendrites, where there were once active connections. Plaques are likely to concentrate in the frontal and temporal regions and especially around the hippocampal formation, found by Zubenko, Musi, Martinet, Rao, Kopp and Henin in 1989. Neurotransmitters affected in Alzheimer's disease. The onset of AD might impact multiple neurotransmitter systems, but acetylcholine ACH is a neurotransmitter that gets directly affected in AD. Acetylcholine is synthesized in a group of neurons called the basal forebrain cholinergic complex BFCC, which is subcortical component of the limbic system and a major source of choline for the hippocampus and cortex. Acetylcholine plays a very important role in memory and has been reported by researchers. Drachman in 1977 demonstrated that blockage of receptors causes memory loss even in young adults. In AD, the devastation of the BFCC neurons profoundly depresses brain levels of the ACH, perhaps as much as 60 to 90%, found by Terry and Davis in 1980, Bowen, Benton, Spillane, Smith and Allen in 1982. Other neurotransmitters that are involved in Alzheimer's disease are one way or the other are catecholamines, the amino acids, the glutamate and the neuropeptides, somatostatin and corticotropin. Neuropsychological symptoms of the Alzheimer's disease. The clinical presentations of patients with AD can vary, but many share similar patterns. Memory and fluent anomic aphasia are two of the most evident and consistent deficits across patients with AD. Below is a description of the neuropsychological and behavioral symptoms and signs in AD. Memory. Memory gets profoundly impaired in Alzheimer's disease. New declarative learning problems at levels of encoding, storage, retrieval and retention over time are usually significant. The AD leads to deterioration of the faculties and structures of the brain that hold previously learned semantic knowledge in an organized and well-associated framework, as a result of which short-term memory span gets affected and vital information related to one's life like names of family members, family stories, etc. start to evade the memory. According to Zillmer et al. In 2008, the only type of learning that appears to be persistent lies outside the corticolimbic system with certain types of non-declarative learning. Declarative memory can be divided into episodic and semantic memory. People with senile dementia of Alzheimer's disease, that is SDAT, have problems in both. They show marked impairment on both verbal and visual learning tasks. There is greater impairment in encoding and consolidation. Since encoding and consolidation gets impaired, retrieval also gets adversely affected, as retrieval depends on proper encoding and consolidation of the information. As suggested by neuropsychologists, semantic clustering, which is the ability to organize new information semantically as they are attempting to learn, it also seems to be absent in patients with cortical dementia. Thus, if presented with word lists that have inherent semantic categories such as fruits, vegetables, etc., most people learn and recall information within semantic categories, clustering the information together. Instead of semantic clustering, patients with Alzheimer's can be seen showing serial ordering of primacy and recency effect. Language and speech. Language and speech difficulties are associated to be a great extent with AD. In AD, as the disease progresses, the aphasia also gets worsened in both degree and type. Anomic aphasia, which is characterized by word finding and naming difficulties, marks the initial stages of the disease. As exemplified by Hodges et al. In 1991, a patient with AD is more likely to say tool for hammer or some type of musical instrument for harmonica, indicate that he or she recognizes the semantic category but can retrieve only the general category or the wrong exemplar for the same category. As dementia progresses, comprehensive problems begin to appear, followed by problems in repeating information, and lastly declining into a global aphasia. Tests such as Boston Naming Test, the Boston Diagnostic Aphasia Examination, the Western Aphasia Test, and the Token Test with reporters tests can be used to test language skills. Executive functioning. Perseveration of thought can be easily noticed by family members of the patient with AD. It becomes evident as the person tells stories over and over or asks questions repeatedly. Frontal impairment leads to many apparent personality changes, and the person can very well be seen losing his or her flexibility. Repeated behaviors such as checking, rechecking may emerge from the combined effect of a poor memory and increased perseveration. The capacity to self-monitor, that is, to regulate one's own behavior and performance, is lost, and the patient with AD appears to lose the overall metacognitive awareness. Visuospatial functioning. Middle stages of AD are characterized by visual spatial problems. Patients with Alzheimer's disease are not able to orient themselves to the environment properly. They find it difficult to navigate new routes and feel unsafe while driving. As a result, patients with AD usually show poor performance on a number of visuospatial measures. As in the other functional domains, the degree of impairment corresponds to the stage of dementia. According to Zillmer et al. In 2008, tests of line orientation, for example, Bonton judgment of line orientation test, spatial construction tasks such as Weiss-R design, copying such as Ray-Ostereth complex figure test, Bender-Gestalt, drawing such as clock drawing test indicate the presence of AD. Visual perception can be studied by the use of variety of tasks such as Golin incomplete picture test and the Hooper test. Attention can be monitored by tests such as reaction time tasks or by continuous performance tests. Complex tests such as Ray-Ostereth complex figure test appear more sensitive to impairment in the early stages of the disease than are simple drawing tasks meant to detect the disease. Motor and sensory function. Motor and sensory abilities are relatively preserved throughout the course of AD, suggesting that simple motor speed and strength persist until late in the course of dementia. In the list of motor and sensory functions that decline earlier in this complex motor behavior involving coordination and skill movement. Except olfaction, the disease processes appear to spare other sensory functions, that is, visual, tactile and auditory. Olfaction is the only primary sensory area affected. Sense of smell is compromised even in the mild early stages of the disease. Many patients with AD report visual disturbances such as difficulty in reading, interpreting pictures and recognizing familiar people. In regard to motor movements, praxis can be evaluated by tests such as those in which patient copies a drawing, cube, daisy, clock or house, or performs the block design subtest of the Wechsler Adult Intelligence Scale. Mood, emotion, personality and insight. In some patients of Alzheimer's disease, the symptoms include mood fluctuation, emotional disturbance and personality changes. The symptoms such as depression may represent an additional disorder. Suspiciousness of others and frank paranoid delusions may accompany memory dysfunction, found by Zillmer, Spears and Culberstone in 2008. Treatment and prognosis. There are no drug treatments available that can provide a cure for Alzheimer's disease. However, medicines have been developed that can improve symptoms or temporarily slow down their progression in some people. Alzheimer's disease is invariably progressive. Patients usually don't die directly from Alzheimer's disease, but rather from neuropsychological and physiological difficulties that manifest themselves during the course of the disease. The patients may die due to difficulty in swallowing or walking. These changes increase the possibility of severe infections, several infectious diseases such as pneumonia. Most persons with Alzheimer's disease can remain at home as long as assistance is provided by caregivers as the disease progresses. Throughout the course of the illness, individuals maintain the capacity for giving and receiving love, sharing warm interpersonal relationships, and participating in a variety of meaningful activities with family and friends. A person with Alzheimer's disease may no longer be able to do math, but still may be able to read magazine with pleasure. Playing the piano might become too stressful in the face of increasing mistakes, but singing along with others may still be satisfying. The chessboard may have to be put away, but playing tennis may still be enjoyable. Thus, despite the many exasperation moments in the lives of patients with Alzheimer's disease and their families, many opportunities remain for positive interactions. Challenge, frustration, closeness, anger, warmth, sadness, and satisfaction may all be experienced by those who work to help the person with Alzheimer's disease. The reaction of a patient with Alzheimer's disease to the illness or his or her capacity to cope with it also varies and may depend on factors as lifelong personality patterns and the nature of severity of stress in the immediate environment. Depression, severe uneasiness, paranoia, or delusions may accompany or result from the disease, but these conditions can often be improved by appropriate treatments. Although there is no cure for Alzheimer's disease, treatments are available to alleviate many of the symptoms that cause suffering. Summary: dementia is a progressive cerebral failure. Dementia may be cortical or subcortical in terms of regions of the brain. Alzheimer's disease is a significant manifestation of dementia. This is a disorder related to the dysfunction of the production and utilization of the amyloid proteins which block the synaptic pathways in various regions of the brain. The predominant symptoms are progressive memory failure and several other neurocognitive dysfunctions such as language and speech, executive functioning, visuospatial functioning, mood and personality disorders. There is no specific treatment for AD and therefore the prognosis is very bleak.